Greetings. Welcome to another edition of our Game Changers virtual series put on by the UNC Health Foundation, which raises private funds in support of research, patient care, and education across UNC Health and the School of Medicine. My name is Martin Baucom, and I'm Vice President of Development for the Foundation. We developed this series early on in the pandemic as a way to let you, our supporters, hear directly from some of the brightest minds and research leaders about a topic that at the time was new to us all. It's close to 2 years later, and I'm afraid it's no longer a new topic, but as the virus has mutated and societal circumstances have shifted, there's still no shortage of new questions, and that's especially true now as the virus seems to be more widespread than it has since all this started. So our initial goals for the program really are still the same, and we appreciate all of you being here. We also very much appreciate the time and commitment extended to this series by our experts like Dr. David Weber from the Division of Infectious Diseases, and certainly by our leadership, Dr. Wesley Burks, CEO of UNC Health and Executive Dean of the School of Medicine. But just as a reminder, I'd like to encourage all of our guests to use the Q&A feature to ask additional questions of our speakers during the program. And I'm now going to hand things over to Dr. Burks to give us an update on our overall COVID-19 response and really what the current landscape looks like across UNC Health.
So
Dr.
Martin,
Burks.
thank you. And thank the rest of you for joining us today. And I'm excited to be joined by David. Many of you know him from attending some of the previous webinars, but he is the Charles Addison and Elizabeth Ann Sanders Distinguished Professor at the UNC School of Medicine. And he's one of the world's truly foremost experts in infectious diseases and in particular infection prevention. I feel like personally, we've been so fortunate to have him as a leader for UNC Health in our big picture response to the pandemic, as well as really helping significantly in our university's response over the past couple of years. I've said this many times, I cannot imagine having gone through this without David around. I know he'll talk about it in the next few minutes in more detail, but the rise of Omicron in our community has created a new round of stress for our teammates, the people I work with all across the UNC Health system and the School of Medicine. We're seeing record numbers of infections and hospitalizations over the last few weeks. And I can't say it's not difficult as we deal with this new surge. Despite that, though, there are things that happen every day that show the strength and the compassion that our healthcare providers, as well as our faculty and staff and students in the school, are doing to meet the demands of this new surge and this new variant. So turn it over to David and looking forward to his discussion with us today. So David, thank you.
Thank you very much for those kind words, and I'm happy to provide an update if you want to put the slides up. And I want to thank everyone for taking time out from their day to hear this. Next slide, please. So we have increasing cases and hospitalizations due to Omicron. Hospitalizations are largely limited to unvaccinated and immunocompromised individuals. As of today, we have approximately 200 people here at the UNC Medical Center hospitalized due to Omicron. Although the disease is less virulent than Delta, of course, if we have 500,000 to 1 million cases a day, we do see increased hospitalizations. Omicron is now the dominant variant. It's highly transmissible. It does escape from many of our previous monoclonal antibody therapies. I'll talk more about that. It does escape largely from people who've had previous Delta infections and people who are fully vaccinated. But if you've been boosted, what the CDC now calls up to date on vaccines, you have good protection against infection and even better protection against serious disease. I'll talk to you and I'll show you the data that there's a lower frequency of serious illness, hospitalizations, and deaths. It has a very short incubation period. The median is 3 days. In fact, it can be as short as 1 day. This really makes it impossible to perform standard public health contact tracing and then having people isolate or quarantine depending upon illness, because it would mean the day you became sick, you'd have to get tested, get the result the same day. And on that same day, the public health department would have to contact everyone. Otherwise, there would already be a secondary transmission. Here is some of the good news. We do have a number of drugs that are active against Omicron. These are the drugs that we use for mild to moderate illness. They're in limited supply except for remdesivir. Two of them are oral, Paxlovid and molnupiravir. The top three are all about 80 to 90% effective. Molnupiravir is a little less effective. Stratuvimab is a one-time infusion of monoclonals, and remdesivir is used off-label, but it is recommended by NIH, and it's infusion for 3 days. So that is our preferred drug for inpatients, and about 30 to 40% of our patients in the hospital, that 200, were admitted for reasons other than Omicron. They were asymptomatic and incidentally found to have Omicron, since we test all of our admissions. Another advance in therapy is a combination monoclonal called Evusheld. This can be given IM, and it's given to people pre-exposure who are high risk for disease, highly immunocompromised, and provides protection from 4 to 6 months. In terms of protection for everybody, vaccine series plus booster, what CDC calls up to date. We follow universal pandemic precautions in the healthcare, and of course, masking in the community is highly protective. And certainly both for our healthcare providers as well as everyone else in the community, we like to avoid presenteeism that is going to work while ill. You should stay home and contact your healthcare provider or your occupational health service. Next slide, please. This is the latest data on Omicron, showing how it is now the dominant variant. In the upper right is the CDC data. You can see it's over 90% of variants described throughout the United States, and you can see the rapid rise over the last 6-8 weeks. In the lower right, just to show you the different waves we've had, the initial alpha wave, followed then by beta wave, and then the large delta wave in August through October. And then you can see in purple the rapid increase in the Omicron variant. On the left is we sequence virtually all of our strains. Dr. Melissa Miller, the director of a microbiology lab, does just an amazing job. And you can see here that incredible change from in orange, in purple, the drop in Delta, and the increase in orange of Omicron. And our last run, which is already now a week or so old, we were over 90% Omicron. Next slide. Here is some just recent data from a couple of days ago from the New York Times. You can see here on the left, average cases almost everywhere in the United States is very hot. On the right, the risk for unvaccinated people based on cases and test positivity remains extremely high. And I'll talk more about that a little later. Next slide. That said and done, there is some good news, and here is the good news. You can see here in the Northeast, which led us by a couple of weeks in Omicron. And also, if you look at the data from the United Kingdom, over the last week, they've all seen a downturn in cases. There's always a little lag between hospitalizations, which is still increasing, but UK is reporting a decrease in that as well. I do want to point out that we're starting at such a high level with between 500,000 and 1 million cases a day that it's going to take probably through mid-March before we really see getting us back to our baselines of cases. But I do expect that by the end of this month, we will be downturning here in North Carolina. Next slide. And I just want to show you an outbreak here. That's how instructive it is. So here was an outbreak. I'll point out 96% of the people were fully vaccinated, but none were boosted. And the attack rate was 74% there, demonstrating that being fully boosted is not entirely protective against Omicron. I also want to point out that all of these individuals had been tested and tested negative before attending this indoor party in which they were unmasked. So masks would have been protective, but they were eating and drinking. So I want to say this again, very important, that testing is not a prevention strategy. Vaccines and masking are prevention strategies. Testing is critical to know who's infected to stay home so they don't infect their colleagues and friends. And it's also critical for knowing who we should consider for therapies to prevent serious disease and hospitalization, but it's not a prevention strategy. And you're all familiar with the many outbreaks on football teams, basketball teams, and cruise ships. And on those sports teams, they're getting tested every day, but they still have outbreaks. Next slide. Here, I just want to talk and switch to antigen testing. You now know we are all eligible to get tests. The antigen tests, that the home tests, are not as sensitive as the PCR tests that we use in the hospital. But for people who are symptomatic after several days, a positive test should be considered in general as indicating infection. But early on in your initial symptom course, a negative rapid test does not exclude COVID. Next slide. And I want to show you, this is quite easy to see in the upper right in those little orange dots there. You can see here that those are all false negative tests. So in the first 1 or 2 days of Omicron, a negative antigen test would not rule out disease. So you really have to wait to about day 3 for those tests to be positive. In addition, per Dr. Miller, you can have false positives from those tests. You need to follow the package instructions very carefully. You can't use a sample from the throat, for instance. If you've had something acidic like orange juice or Coca-Cola, that can give you a false positive test if you're asymptomatic or early symptomatic. So you really need to follow those guidelines quite well. Next slide. Now, one of the interesting things about Omicron is because it's a slightly more mild disease, a very large number of asymptomatic individuals. This was a nice study out of South Africa where they were studying how well COVID vaccines worked in HIV positive persons. So these were all unvaccinated people coming in to join a vaccine trial. They were all asymptomatic. They were screened for symptoms, and at baseline, they had a COVID test. And you can see there were a whole series of individuals there that were testing only about 0.6 to 2.4% of those asymptomatics were testing positive. During the Omicron wave, 31% tested positive. As just more examples of that, about 30 or 40% of our patients admitted to the hospital have Omicron incidentally found. They're asymptomatic. And we test all admissions to our hospital, as well as people coming in who will have surgery and stay overnight. And at last week, over 20% of our asymptomatic people were testing positive. Next slide. Now, what about household transmission of Omicron versus Delta? First, let's look at the Delta. That's the reference group. You can see that if you were unvaccinated, you had about 2.5 times the risk of getting Delta than if you were fully vaccinated. And if you were boosted, you dropped your risk by 2/3. With Omicron on the left, being fully vaccinated versus unvaccinated in this particular study, a relatively small study, being fully vaccinated did not indicate protection, but again, getting boosted, it dropped your risks by 50% for getting infected, and the vaccine's even better if you're boosted for preventing serious illness. Next slide. Now, what about clinical outcomes? I mentioned that Omicron is less serious. Here's a nice study out of California. In purple is the Delta wave, and green is the Omicron. And you can see lower risks for hospitalization, ICU admission, mechanical ventilation, and fortunately mortality as well. In addition, people are symptomatic for a shorter period of time with Omicron. So that along with the somewhat dropping cases in the Northeast are both good news, as well as the fact we do have a number of drugs that are effective against Omicron. Next slide, please. Now, what is the explanation potentially for some of the increased infectivity but lower virulence? This was a very nice study where they looked at the amount of virus in the bronchus and upper airways versus the lung. They did find that the Omicron variant multiplied 7 times faster in the upper airways. So this may account for part of its increased infectivity, along with the fact that if you've had previous infection or vaccination, you have limited protection, but it had lower rates of replication in the lung, which likely accounts in part for the fact that it's not as severe a disease. Next slide. Thank you very much. This will end part 1. I know it all feels like we're playing whack-a-mole here, stamping out one variant or another, but we are very experienced in how to do this, and we certainly have a number of bright spots during the Omicron wave. Thank you.
So David, thank you. And we'll try to take some questions that have been sent in ahead of time. There's one in the chat room now, and someone's asking about other variants. They've read about one in China. What's the likelihood of other variants either being more or less virulent going forward?
So it's certainly likely that for more variants, if we see them, and I say that's sort of like predicting, when we'll have a hurricane in Chapel Hill. It's really hard to predict that. You know one is going to hit eventually, but you have no idea when. And that's the same way with variants. There's no way really to predict it, particularly since the Omicron variant wasn't derived from Delta, it was derived from earlier variants. So certainly if it's going to propagate, it will probably have to be at least as infectious as Omicron. When you looked at some of the other variants like Delta plus and Mu, they never became important because they were outcompeted by Delta. But we need to remember that transmissibility and virulence are really separate factors. And here we have one that's more transmissible, but much less virulent. And similarly, transmissibility may not entirely be linked to escape from vaccines and others, although that certainly would aid it. So I don't know that we can predict that when we'll see another variant, how severe it'll be. There doesn't appear to be anything in the immediate horizon that will outcompete Omicron, though.
Okay. So David, related to testing, just a couple of general questions. One for a person. So if I'm having symptoms, what would make me want to get tested? And if I'm going to get tested, what would you recommend? At-home test, if you can get them available, to try to go get a different type of testing? And does the testing, both at home and the other types of tests, indicate which variant it is, or does it really matter?
So at this point, the testing can't help separate which variant it is, but that's really not material right now, since virtually everything is Omicron. If you're symptomatic and you test positive and you've done the test correctly with a home test, you should consider yourself positive. I don't see testing to at 5 days or 8 days to look for a negative test to prove you're negative and it's safe to go out. In general, if you want to be absolutely safe, wait 10 days from the onset of your symptoms or the first positive or your positive test result, and you will not be infectious after 10 days. CDC does say that you can, after 5 days, if you're feeling better, afebrile, off drugs, and vaccinated, you can go out wearing a mask, but that does have some risks for other people. So I certainly wouldn't go visiting unvaccinated people, immunocompromised people, and others. And ideally, you'd wait the 10 days. If you're symptomatic and the test is negative in the first couple of days, and you're not at high risk for serious disease, you can just wait and retest yourself at day 3. If you're at high risk for serious disease, meaning older than 70, underlying immune problems such as cancer, immunosuppressants, others, then you should call your healthcare provider and get a PCR test, because all of the therapies I mentioned, the earlier you get them, ideally within 5 days of symptom onset, the better they work. And you should never consider a negative test if you're symptomatic as being 100% accurate. It's best to, unless you have another diagnosis, best to avoid people who might get very ill if they get Omicron.
Okay. So David, a couple of questions from the chat room right now. A question about the recommendation that you might have about the combination of flu and COVID vaccine as opposed to individual vaccines. And how's that different in the more senior individuals?
So you can receive a COVID vaccine and a flu vaccine, or for that matter, a pneumococcal vaccine simultaneously. They haven't built them into the same syringe and the same vaccine, but you could get them in different arms at the same time. And the data shows they all work equally well if you get multiple vaccines. We are seeing a steady number of flu cases with a slight uptick in the last couple of weeks, certainly not to epidemic proportions, but certainly if you're older and vulnerable, there's plenty of time to get your flu shot. We do expect flu will be with us through April, May, or June this year. So certainly encourage people to get their flu shot, and you can get the vaccines at the same time. Now, in terms of the other flu shot, it takes about 2 weeks to build up good immunity. That's true for the primary series for COVID. But if you're getting a booster shot, that will work almost immediately because it's only increasing the antibodies you already have. So really, the day after you get a booster, it's already beginning to work.
Okay. So David, we have another question. One of the the guests is just their personal experience with Omicron and patients being admitted. What do you make of the delayed increase in deaths in South Africa and the increased number of deaths from usual that they are now seeing?
So of course, what we see is from the cases, there's always a lag between cases and hospitalizations of about a week to 2 weeks. You have to get sick enough to get hospitalized. And then there's another lag of a week to 3 or 4 weeks for the deaths because of our very good inpatient care, ventilators, ECMO, drugs. So there's always going to be a lag. I just saw some data suggesting we're, as you know, over 850,000 deaths from COVID. 1 in 100, more than 1 in 100 Americans have died, and both for 2020 and 2021, COVID ranks as the third leading cause of death in the U.S. But we are expecting before Omicron surge ends somewhere between another 50,000 and 300,000 deaths from COVID, unfortunately. So likely by around April, we'll surpass 1 million deaths in the United States from the beginning of the pandemic.
Okay, David, there's been some information coming out of Israel about giving second and now third boosters. Do you have any thoughts about what's likely to happen here in the U.S.?
So of course, we are now giving third doses or a booster for all people. We've begun giving fourth doses for immunocompromised people. They can get that 5 months after their third dose. Fourth dose, we'll have to wait and see how much additional benefit it'll have over a third dose. Both Moderna and Pfizer expect to have Omicron-specific vaccines available by March. So I don't expect in the U.S. we'll see a recommendation for a fourth booster the way they're doing in Israel. Not many people would be eligible since we're not really at the 5-month time period for that. We'd have to give it earlier, but we'll see what happens and when those vaccines become available, whether there'll be a recommendation to get an Omicron booster.
Okay, David, you talked in the original slide about the treatment options that are available right now. A couple of thoughts here. One, if you could talk a little bit more about the availability now, which you did, and then going forward. And also there are some other treatments out there that people have talked about that really you didn't list. Just some comments about those other treatments and whether they're something that people would want to do.
So yes, all of these are in short supply with the exception of remdesivir. That does have some challenges because it's an IV infusion each day for 3 days. So that makes it difficult for our patients in our infusion center. For people with mild to moderate disease, that is our preferred therapy. I should say I didn't mention the therapies we have had and continue to have, such as high-dose steroids, prone ventilation, remdesivir for more serious illness, and we continue to use all of those modalities. They work against Omicron as well. Paxlovid, because it's oral, is our first choice, and Stratuvimab, because it's a single infusion, is our second choice. Those do remain in short supply, so we've prioritized those who are most likely to benefit to those. And then we do have reasonable supplies of molnupiravir. It's less effective, but that has some potential for shortages. We do have adequate supplies and we're using that substantially. There have obviously been a number of drugs that have been shown not to work, specifically ivermectin as one example there. And we do not use those drugs because randomized trials have shown lack of benefit and potential harm. So we do not use those drugs that have been demonstrated where the risk exceeds the benefit.
Okay. David, just some general advice for individuals, for people in the audience about what you talked about, like wearing a mask and distance precautions. What would be your recommendations, your thoughts about going out to eat, going to the dentist, other things like that? How can you help people think about that right now?
Well, the two best strategies first are if you're not vaccinated, get vaccinated. If you're not boosted, get boosted. Masks work, and there's no question about it. Ideally, a medical mask is preferred over a homemade mask. Homemade masks can be as good as medical masks, but they're not standardized, so some can be inferior. anything you can do then to improve the fit gives you much better protection. Just with simple things, you can make a medical mask 50% better. So you can tie it where it just comes out from the mask. You can put a hair clip and pull it tighter. You can put a gaiter and double mask over over a mask. All of those improve the fit tremendously and the effectiveness of the mask. Of course, CDC now says you can wear a KN95 or an N95. I will caution you that 60% per CDC of KN95 sold on the market are counterfeit, and they do not have to need to fit correctly. So in general, I favor a well-fitting medical mask. And if you're in a situation where you're masked and everyone else around you is masked because there may be infectious people near you, masks, by the way, are very efficient in preventing the expulsion of infectious particles. So if everyone's masked, your risks are relatively low. So your risks really being outside of your household bubble and being in situations where you're in close contact with unmasked people. So eating and drinking at bars and restaurants inside, at least for the next 4 to 6 weeks, is probably not a good idea. And certainly large family gatherings, particularly if there are younger individuals, teenagers, young adults who may be less compliant with masking, that's where we're seeing most of our transmission at the moment. So vaccines and masking, highly effective. If you're unmasked, physical distancing by 6 feet will largely prevent infection as well.
Okay. Speaking of the vaccines, there's a few questions about the different types of vaccines and the value of mixing and matching. Walk through with us your thoughts about that.
So let me first start off with the J&J vaccine, which was only a single dose vaccine. It clearly was not as effective as the 2-dose mRNA vaccines. Anyone who's had the J&J vaccine clearly should get a second dose as recommended by with an mRNA vaccine. And at this point in time, I would not take a J&J vaccine. I go right to an mRNA vaccine. Both the mRNA vaccines are, when boosted, are very effective, but Moderna is slightly more effective than the Pfizer vaccine. So if you're going to start fresh, I'd probably get the Moderna vaccine. Boosting is a little less clear because in the mix and match study done by NIH, they used 100 micrograms, which is the primary series for Moderna, but the boosted vaccine is 50 micrograms. So my guess is for boosting, they're probably quite similar. I will show you some data. And if you want to, there's no reason you can't. For the primary series, you should get both doses of the same vaccine, but for the booster, you can pick either Pfizer or Moderna, regardless of which one you received.
Okay. Regarding vaccines and masks, there's a follow-up question about someone asking if you're going somewhere where you're wearing a mask, but others are not. Tell us what your thoughts are there.
Well, certainly the mask remains highly effective, but clearly somebody who's near you without a mask, who's infectious, spewing out lots of particles, even if you have your mask on, there is some small risk that you would acquire it either because of breathing air around the mask or even through the mask or through spread to the eyes. So again, it would be best to avoid those circumstances where you're masked and they're not, but it does remain highly effective. I will tell you in the hospital where we use masks for taking care of patients, many of whom can't wear a mask themselves. Going back 2 years, we just did not see transmission to our healthcare providers in that situation. And in our COVID units, when we looked at our first 1,500 COVID patients, we could only find 2 possible, and I say possible, cases with transmission to our healthcare providers. But they, of course, were in N95s at that point in time.
Okay. There's a question from earlier about, and you talked about this, but just to go back over it, about the length of time that I have the ability to pass the infection on to others. What's that? Go over that kind of range.
Sure. So it certainly decreases as you get better, meaning after 5 days, it's decreased. But we know that for a healthy person who is out of the hospital, it does not exceed, you do not excrete viable virus for more than 10 days. So day 11, you're free to go out and you will not transmit virus. If you are sick enough to be hospitalized, or you're immunocompromised, severely immunocompromised, such as a cancer patient, as an example on chemotherapy, or a rheumatologic patient on Remicade, or an organ transplant. Those people can remain infectious for 20 days. And again, it's best to follow a time-based strategy is best. Now, you may test still positive after that by antigen or PCR, but that doesn't mean that there's viable virus there. Certainly, if you tested negative by PCR, then you would be non-infectious. But in general, people may test positive even after those periods of time, but there's not viable virus.
Okay, and again, the follow-up question here is that transmission is there any transmission through contact?
So most of the transmission is by somebody sneezing or coughing out particles, and you're breathing them in. There are a couple of examples that suggested contact transmission. The virus does live on hands for minutes to a few hours, and does live on surfaces for a number of hours. So there is theoretical that if you touch something, rub your nose, you could get transmission. There are 2 outbreaks I'm aware of that were both believed related to elevator buttons of all things, one in a mall and one in an apartment building, where the infectious people and the non-infectious people had no direct contact. And there is one case described in an airplane where an infectious person wore their mask the whole time, but then went into the bathroom and touched a number of objects. Someone else went into the bathroom not sitting near this person and did acquire COVID. So there is some small potential for person to transmission by touching. Alcohol kills this in literally 10 or 15 seconds. Any surface disinfectant kills it, but most of the transmissions directly by air.
Okay, good. So why don't we stop with some of the questions, and we'll come back to them in a few minutes. But if you want to go ahead with the next part of your discussion.
Thank you very much. So here's the impact. I want to point out the impact of COVID on deaths, and you can see here that depending upon what wave we were in, many times was the leading cause of death in the United States overall for 2020 and 2021. It'll be the 3rd leading cause of death. I want to show you to the right that for people, older individuals, for much of the last 2 years, COVID has been the leading cause of death. And while we don't think of it in children as being as serious a disease, which it's not, we have had a substantial number of deaths in children. And you can see here that for depending upon what wave we're in, it was ranking in the top 10 causes of death among children. So, and we are seeing more children with the Omicron wave. Next slide. I want to talk a little bit about long COVID. It does occur in children, it occurs in adults. I'll just point out to you here, as you know, COVID is a multi-system disease. Long COVID can lead to declines in life function, fatigue, joint pain, lung problems such as ongoing dyspnea, a lot of neuropsychiatric problems, what's called brain fog, cognitive disturbances, anxiety, cardiac problems, and many others. But in this study of survivors here, 1 in 3 patients had 1 or more features of long COVID between 3 and 6 months after a diagnosis there. And this was much higher than, say, after influenza. 2 in 5 of the patients had long COVID features in the 3 to 6 month period, had no record in the previous 3 months. So it's not just that people with underlying heart, lung, kidney disease, strokes are feeling worse in their respective system that was abnormal. They can have whole new symptoms. And the risk of COVID is higher in patients. The more severe the disease you had, the older you were, and the more comorbidities you had, the more likely you are to get long COVID. But even if COVID disappeared today, these problems will remain with us for months to years to come. Next slide. I do want to show you, this is kindly provided by John Barada, who leads our COVID clinic. He's from physical medicine and rehab. These are the age distributions of the patients we've seen. You can see we've seen around 700 cases. Dr. Barada has done an amazing job, and I do want to thank Dr. Burks for the support from the Dean's office to start this important clinic, which is the first to start in North Carolina and the largest there. And you can see that most of the people coming into the clinic who have symptoms more than 4 weeks have been in the age range of sort of 40 to 70. it's more likely the symptoms occur in older individuals, but they're a smaller part of the population. And while our clinic will see adolescents, it doesn't see children, which is why you don't see anyone 0 to 12 represented. But I would certainly encourage, if anyone you know is having symptoms after 4 weeks, to make an appointment and see Dr. Barada in his clinic. Next slide. Effectiveness of COVID vaccines over, this just was published, you can see just 2 days ago, so I'm showing it. This is before the Omicron wave here, but I just want to point out to you how well the vaccines were working in preventing deaths up until Omicron. Vaccine effectiveness against COVID-19 was roughly 95% at 2 months after the first dose, decreased somewhat with subsequent doses, but still remained much better at preventing hospitalization. So it decreased to about 70% to prevent illness, but it got much better than for hospitalizations, and very effective for preventing deaths. And of course, the J&J vaccine is less effective than as a single dose vaccine than was the mRNA vaccines there. And this is true for many, many vaccines like flu vaccine. They're much more effective at preventing hospitalizations, that is ameliorating disease, than preventing deaths. Next slide. Omicron does evade neutralization by sera from vaccinated, and I want to point out convalescent individuals there, so that people who have had previous infection are likely from Delta to get reinfected with Omicron. But if you're super immune, the box H on the right there, these are people who have been infected and vaccinated once or twice with an mRNA vaccine. They are very able to neutralize Omicron. So again, even if you've had natural infection, it's really critical for people to become vaccinated. Next slide. Now here again is looking at vaccine effectiveness against Delta and Omicron. Again, this is for infection, not serious disease. And you can see that for Omicron, with time, it does decrease more than the vaccine did against Delta. And essentially, even after 2 doses, is really not very effective for preventing disease. However, once you boosted, we had this question on the middle one with Pfizer, or on the right with Moderna. You can see you get a excellent response there. You can see Moderna is a little bit more effective than Pfizer there, and you get almost back to where you were with Moderna 2 against Delta there. And we'll just have to wait on how that holds up over time. So I hope this answers a number of your questions. Next slide. Now, I do want to point out about children. Of course, in the US, only about 2/3 of the population is fully vaccinated. The US ranks somewhere between 50th and 60th in the world in its vaccine coverage. So this is a major problem I'll talk about in a minute. Only about 1/3 of the US has had a booster dose, so that's something we have to push on. One of the reasons we're seeing younger individuals more with Omicron, you can notice in the uptake in 12 to 17-year-olds for vaccine has been quite good. But if you look at the 5 to 11-year-olds, it has substantially lagged. So that's a group we need to target. And because we have such vaccine resistance in the US, 20–25% people just saying they will not take the vaccine under any circumstances unless it's required. And that hasn't budged, by the way, in the last year and a half, essentially. The hesitant have, but the resistant have not. I foresee that for the foreseeable future, meaning all through 2022, people who are unvaccinated will continue to come to our hospitals, will continue to get sick, and continue to die. And so we have this increasingly disparate world of the vaccinated, boosted, and continued boosted, and the children vaccinated, and the totally unvaccinated group in terms of the impact of COVID. Next slide. Now, one of the reasons that I should say that vaccine is not taken up in adolescents is concerns about myocarditis, and I'll mention that. But here again is the effectiveness of the vaccines against adolescents. Vaccine, again, prior to Omicron, 98% effective against ICU admissions and against COVID-19, resulting in the receipt of life support. So, and all the deaths were unvaccinated. Again, why we really need to push hard on vaccinating adolescents and children. Next slide. I do want to point this out. So we see a lot in the newspaper about one of the complications of the mRNA vaccine, which is myocarditis, inflammation of the heart, and that is true. But the risk is really the highest risk is in young males, and it's about 1 per 10,000. If you look at the risk in studies where they've looked at athletes in high schools and colleges and tested them routinely for SARS-CoV-2 when they turn positive, done more specific tests looking for cardiac involvement, you would see about 1% of those people develop cardiac involvement. So a 1 in 100 risk after natural COVID of getting cardiac involvement, a 1 in 10,000 risk of getting some cardiac involvement after a vaccine. So you can see that the benefits way exceed the risks for young people to be immunized. Unfortunately, the news media has not done a very good job of talking about the risks of COVID to young individuals. Next slide. There is considerable escape of SARS-CoV-2 variant from antibody neutralization. You can see a number of the drugs we used, such as BAM and EDI. You can see those green lines and those red lines just staying flat, having no effect. We are no longer using products like the Lilly and Regeneron products, but you can see the ones I highlighted in red, Evusheld and Sotrovimab. They are not quite as effective, but more than effective enough to be excellent therapies against Omicron. Next slide. And so here's what we do for before infection, what we're currently using. We're using Evusheld to prevent infection. We don't have any post-exposure prophylaxis drugs at the moment, but we do have 4 drugs for treating mild to moderate disease that are listed here. And if we carry that arrow on, we have a number of therapies for sicker patients in the hospital as well. Next slide, please. And new CDC mask guidance here. Which is you can wear an N95 or a KN95 there. I just want you to keep in mind that, as I said, 60% are counterfeit. The KN95s are not standardized. We did some studies here of them. That is Dr. William Bennett, one of our aerosol engineers. Studies were led by Dr. Emily Sigbert Bennett, his daughter, who's the director of infection prevention here. One KN95 was 88% effective, almost as good as an N95, but another one was 30% effective there. I do worry about shortages there. These masks are sized and you have to wear the proper size there. Many people feel claustrophobic or have difficulty breathing with these masks. So the best mask is one you wear all the time, as the CDC notes. If you're constantly taking down the KN95 to breathe better, that puts you at risk. And there are actually no studies that demonstrate, epidemiologic studies, that the KN95 or N95 is actually better than for COVID protection than as a regular well-fitting mask. Next slide. I do want to point out, here's our actual data. You can see the KN95 in red, the top one was 85% effective. The bottom one, another one we tested, was 53% protective. Some is not done as well. Lots of simple ways here, like is tying the loops, increase your protection by 40%. A little hair clip pulling it tight goes up to 70%. And if you put a nylon hosiery over that, or a second mask, you get up to about 80% there. So that's almost as good as an N95. Next slide, please. So again, I'm happy to answer any additional questions.
David, if you could keep on talking about the mask minute, there's one question about a KF94, but also you described that a large percentages of the KN95s that are out there are not really that. So give the viewers just some idea. How can you tell? Like if I get on Amazon, how can I tell whether I'm getting one that's appropriate or not?
Yeah, I didn't put it in my slides, but we can certainly send you the link. If you go to the CDC webpage and write CDC, counterfeit KN95s, they'll give you a whole series of clues about that. So things like misspelling, symbols upside down, putting the wrong letters on. There's never going to be any numbering inside the mask. It's always on the outside of the mask. So those are all these masks have 2 straps, not 1. There are a number of simple things you can do just by looking at them that will identify obvious counterfeits. Of course, some of the counterfeits are more made in a more sophisticated manner, and they may not be identified. But CDC does have a nice webpage about to help you identify which ones may be counterfeit there. I should also say these are really designed for single use. So I know the government now, the state has made available, for instance, to Orange County, a number of these masks, as well as to UNC Chapel Hill, but they're not designed to be worn like for 2 months, one after another, like you might wear, your hat or your gloves. They're really designed to be worn only a single time. That would be best. If you want to use them, for 4 or 5 times, then what I would do is perform hand hygiene so you're not contaminating your hands. Put them in a paper bag with the outside down. Take it out of the bag, again, hand hygiene before and after replacing. But you should really be only using them, for no more than 5 days or no more than 5 times before replacing them. Ideally, you'd use them only for a single time. They're not designed for days or weeks of use.
Okay, a little bit more about transmission. There was a question earlier about transmission in the classroom for all different ages. Just some of your thoughts there right now.
Certainly. So as you know, Duke and UNC, we do fight hard over basketball. We do cooperate when it comes to medicine and science. And I'm part of what's called the ABC Collaborative with Duke. And we study transmission. This is NIH supported, led by Danny Benjamin, a former student of mine. We study K through transmission in K through 12 schools here in North Carolina and now around the country. And we have shown, like during the Delta wave, for instance, if the school has universal masking and when they're not masked, physical distancing, 3 feet, not 6 feet, for every 20 cases acquired in the community among children of that age, there was only 1 case acquired in the schools. So I think in general, we can let children go back to school safely. We have another study, it's not yet been published, that shows, not surprising, schools without mask mandates have more transmission than schools with partial mask mandates have higher transmission, and the lowest transmission is in schools with mask mandates. So if we have mask mandates and encourage everyone to be vaccinated, I think in general, it's safe for children to go back to school. But certainly during the Omicron wave, we need to continue mask mandates in school to be safe. The one area of transmission that we do see in high schools, by the way, is important, is in contact sports where people are not masked. So that is one area where certainly increased vigilance. And if you're very risk adverse, that's something you have to consider in letting your child participate in contact sports. And again, testing before sporting events is really not a prevention strategy.
Okay, there's a question about testing and travel. There are a number of different countries, different means of travel that have different regulations. Why might the CDC or a particular mode of transportation like the airline, why might they ask for testing prior to reentry? What's the value of that?
So I think part of it is political and having people not come into the country who are infectious. And certainly I think in a confined space, even with everyone masked, people on a long plane flight have to take off their masks, eat and drink somewhat going, on a 30-minute plane flight, you can, or an hour, not eat or drink. 12-hour flight, you really can't do that. So that has some value. It's not going to help us in the U.S. with 700,000 cases a day. Whether it's a strategy in terms of that. And as we've seen with cruise ships, again, just testing negative a day or 2 before you travel doesn't prove there aren't people there. So again, I would keep your masks on. Other things you can do on a plane is turn the air nozzle on high, right at your face. That'll sort of flush air around you. But largely, it's not the travel that's the risk. It's what you do when you get to wherever you're traveling. So if you travel and then you go to a large sporting event, or you're going to restaurants and bars, or very large family events with lots of unmasked people, that's the risk. It's not really the train, the bus, or the plane that is the biggest risk. It's what you do when you get to the other side. And I certainly do encourage you, one, to be aware of all the restrictions for traveling. And you need to look up not only where you're going to, but also where you're transiting from. The last thing you want to do is fly, from the US to London to get to Paris, get to London, and then find out that the test that you had that got you into London is not adequate to now let you go from London to Paris, and you're stuck in London there. And then the biggest risks are, of course, when you get there, I would encourage people to have some plan about where you would stay if you get ill. Ideally, have both, make sure your insurance covers illness outside of the country. You can usually get a small rider on your insurance, and even better, you can go through one of the plans that would actually back transport you to the US. That's particularly important since very few countries have the level of care that we would give for somebody who's sick. So that's something to consider about evacuation insurance as well if you travel.
Okay. David, there are a couple of questions about COVID in our community, particularly here in Chapel Hill and in the Triangle, about the number of people in and our capacity over the next few weeks, how we're able to deal with it. So just your thoughts there.
Yeah, so certainly we have the ability to take care of all the patients that need care at the hospital. We are stressed but not overwhelmed. We have about 200 today, and how have we done that? Two ways. One, we've turned off and ramped down elective surgery, and I'm not saying that these aren't surgeries that need to happen, but somebody who needs an artificial hip and can wait 6 weeks, we've turned some of those off. And similarly, we've turned off some of our clinic visits for routine care. And so that's one, both opened up hospital beds, other staff to take care of those individuals in the hospital. And so we've not had to envision things like, tents and gymnasiums with care there. Nevertheless, it is stressful for our staff there, and certainly this is not only here but all over the country. People have put off care because of COVID in general. We've seen less care for people putting off care for cancer, for instance. Childhood immunizations, primary immunizations in young children have lagged because of one, inability to come see a pediatrician or family practice doctor, and two, people unwilling to necessarily bring them there with risks about waiting rooms. So that's something we'll have to deal with as this surge is over. But so far, we've weathered it successfully under the excellent leadership in the hospital by just so many people. It's hard to mention. For instance, we're providing 700 or 800 infusions a week in our infusion centers all across UNC Health to keep people out of the hospital. A huge number of that. So we continue to be able to scale up and to keep people out of the hospital as well.
Okay. You mentioned earlier that what we were terming the COVID-related absences for the people that we work with. That from a system standpoint, they reached over 1,000 several days ago, but that's leveled off in the last few days. Go over the recommendations that we use for when people should stay away and come back to work, and then what others in the business community, what recommendations would you say that need to be there?
So at the moment, we are allowing people in critical areas of the hospital to come back after 5 days. There are a whole number of provisos for that. One, those are people who have had COVID. They have to be much improved symptoms, no cough or sneezing, so masks would be effective. They have to be afebrile for 24 hours, not on drugs. We put those people in a fitted N95. They're instructed to eat or drink either outside or in a private room. And we reevaluate the necessity for those people weekly. And as the Omicron surge decreases, we'll go back to keeping them out of the hospital for 10 days. In the community, certainly the CDC now says, again, you can go out after 5 days. But to me, really, that should only apply for people going to work in critical areas. And they ought to follow the rules, which are very similar to what I've mentioned, and otherwise only going out for critical needs, like you absolutely need food. It is critical for those people to wear their masks when they're out of the house.
Okay. So David, thank you again for taking the time to visit with us today. It's an unbelievable amount of information that you've shared, and so we are very appreciative of that. I know you work tirelessly now for almost 2 years. And as I said at the beginning, just my personal comfort changes significantly as you're involved in all of this for all of us. So Martin, I'll turn it back over to you now.
Thanks, Dr. Burks. And as you said, thanks to Dr. Weber for really an incredibly enlightening presentation, and to all participants for the good questions. I know I picked up my K9 N95 mask multiple times to examine it a little more closely for signs of counterfeit. I think it's good, but it does sound like I may need to discard it soon either way. I do want to highlight for you the slide here that has some additional UNC Health COVID-19 resources for all of you. And then if we flip over to the next slide, I'm sorry, actually, I'm misreading that. One of them is our COVID-19 Resource Fund, which we established early on in the pandemic. And it's had a really great impact thanks to your generosity on both research and patient support related to COVID. I'll remind you that our recording today and the PowerPoint are going to be circulated later to all who attended. And if you would, please take a moment to complete the survey when you do sign out. It'll have questions about our program today and its effectiveness, and it also gives you the chance to suggest some additional topics. So I want to thank each and every one of you for being here with us today, and thanks to Dr. Burks and Dr. Weber.